Here we go.
You don't have to live in pain anymore. This is the podcast where you'll learn the stories, tips, and tools to get back to your path to health. I'm Dr. Dudum. This is Back at It with Dr. Decompression.
Hey, this is Dr. Dudum with the Back at It with Dr. Decompression podcast. Welcome back, episode 21. I'm so excited. Today, I'm going to talk about the nuances of spinal decompression, those small tweaks and those small intricate details as a practitioner that I apply that make these tables so useful and ultimately get patient results. Before I dive into the topic, I want to thank our sponsors. We have Pillowise, amazing pillows. I can't talk enough about how they've changed my sleep and a lot of the sleep with our patients. They have this technology and algorithm they use to get the right fit for your neck when you sleep. And also Power Plate. Love the vibration technology that we use not only for my back, for the back of our patients to get relief. So big shout out to Pillowise and Power Plate for bringing you this episode. I only talk about products and sponsors that I use personally. So I want to give a shout out again to them, and they've helped me and my patients. So that's why they support the program and they bring this to you. Let's talk about decompression. On all the previous episodes of 20, I've discussed how does it work, the nuances, clinical studies, etc. And the momentum and the feedback has been amazing. So many questions, so many referrals to other practitioners. I'm so excited. And I want to give a dive in deeper in the brain thinking and clinical, how we use these doc decompression tables. So generally, I've discussed, you can change the angle of the table. You can flex people's legs from 0 degrees to 15 degrees. So you're on your back and they can flex their legs. Discussed how the table laterally bends. Laterally means side to side. So if you're laying on your back, we can tilt you, lay you sideways or angle you left or right. Also, we can change the oscillation. So in one of the episodes, I believe 14 or 15, I discussed the difference between traction and decompression. Traction is a static pull. It's a static pull and holds. Decompression is when the pull and it oscillates. It creates that pumping effect, like an accordion, which really doesn't allow a muscle spasm, but allows the disc to pump. The accordion setting on our tables isn't the same for every patient, meaning you don't go out and then in 50% and out, and it can be out 190, out 100 to 80. Those nuances affect patient results. That's what we'll talk about. So let's talk about 3 different patients, all different, really cool, interesting about how we use the tables and how their MRI and their specific condition, how that affects a very specific treatment plan and use of the tables. Let's talk about number 1. Patient had an L4, L5 lateral disc bulge, which means it's not in the center, it's on the outside where the nerve exits. The nerve exits a big hole. So for you listeners, if you're on your walk, you can't see, I'll describe it for the viewers. You can see what I'm doing. There's a big hole that's created, and there's a small, tiny nerve that exits that hole. When you have a lateral bulge or a bulge that's on the side, it usually can irritate the nerve. And there's a term in these reports. It's called abutting the nerve, and it means it's on the nerve. So typically, if you have a disc herniation, a lateral disc herniation, or a lateral disc extrusion, you will have a budding of the nerve, which means symptomatically that you'll have leg pain to your calf or to your foot, and there will be no give to the leg pain, meaning it's going to be unrelenting. The pain might go from a 10 to a 4, but you will have constant leg pain, numbness, stress in that leg. That's a really strong indicator that there's an abutting of the nerve, meaning the disc herniations on the nerve. So this patient had a lateral herniation on the nerve, occupying 80% of that hole. There's not much room for that hole for that nerve to come out. What we did with this patient, he was an L4, L5. So we tried originally to target the L4, L5, what you would think that we would do. Targeted the L4, L5. Results were about 30% better, but he got stuck. He got stuck and he couldn't get out of the weeds, and we couldn't propel him from 30% to 100%. This happens all the time. It's not a one bullet that fixes everything. We have to find out the formula for each patient. So I had to adapt the table and change the trajectory of his symptoms and fix his back. What I did based on my experience and clinical knowledge is I angled him up 15 degrees from 5 degrees, and I laterally bent him away from the bulge because I wanted to open the hole longer or wider. Sorry, open the hole wider. So I bent him up and I rotated him away of the area of pain in the leg. That had created more space for that herniation to suck back in. Finding the right angle and space to get the disc to come back in is the goal. So using the tables to accomplish that goal is key. Well, 6 weeks after doing this, the patient is 100% better. We just took a photo, his victory photo. He avoided spinal surgery. He's 100% better. He's waking up pain-free. He can walk miles without his hip and his leg irritating him any longer. And he doesn't have the gnawing, constant leg pain that he did. The leg pain altered from a 10 out of 10, which is awful, to a 2 out of 10, which is just simply annoying. So that one change from the L4, L5 angle, flexing his legs and rotating him to open the hole and allow that disc herniation to reabsorb was the key to his success. If this patient was on a table that did not laterally bend, he would not have gotten relief, and he probably would have had spinal surgery. That's the power of the table. And these tables are like Ferraris. If you don't know how to drive a Ferrari, you should not drive a Ferrari to its maximum speed. You might drive 10, 20, 50 miles an hour, but you shouldn't drive it the same as Jeff Gordon that knows how to drive a Ferrari 120 miles an hour, because you'll get injured. So knowing this is super important, and that's how we saved him from spinal surgery. I will keep you posted on this patient in one of our future podcasts. He's getting an MRI in the next few weeks. I would love to share those results with you to show how we actually fix problems. That's just one example. I got two more for you. The next example is an L5-S1 disc extrusion, meaning that the jelly inside the disc has bursted out and it's kind of floating in and around the spinal cord area. This patient has an inferior disc extrusion. So superior would mean up towards the head. Inferior means down towards the sacrum and the coccyx. Again, traditionally, you'd think if I have an L5-S1 disc bulge, why wouldn't you target my L5-S1 disc bulge? That would make sense, right? You can't target an L5-S1 disc extrusion that has gone inferior towards the coccyx. It won't work. The disc will not reabsorb. The spinal decompression program won't work. Have a patient that has a L5-S1 disc extrusion, and we tried that. It didn't work. So what do? You flex at 15 degrees and you really flex open the spine to create a crevice for the disc bulge, for the disc extrusion to reabsorb and come up the crevice and reabsorb. You have to use the table and the angle to find how it's going to help the patient. These are the specific things that I'm thinking about clinically that help so many patients. We don't just strap you on the table, push a button, see you in 30 minutes. I had a patient, this is a side note as we're talking, I had a patient that's getting better, and she asks, hey doc, am I just getting the same treatment every time? Like, I have to continue to educate the patients on what angle we're pulling them on, what frequency are we pulling them at with, and why is that angle happening? What crevice does that create in space and vacuum to reabsorb bulges and herniations and extrusions? So that's why I'm talking to you on this podcast, to show you how and the thinking that goes behind disc reabsorption with spinal decompression. So this patient with that was a tangent. I just went on a big tangent. This extruded inferior disc at L5S1 couldn't sleep, waking up 7 to 8 times a night because the pain in her butt down her leg was so intense. Well, finding the right angle means the disc bulge will reabsorb. The disc extrusion will reabsorb. It's reabsorbing. The pressure is taken off of the nerve. The nerve is healing. When the nerve heals, the leg and foot pain will start to go away. It'll start to hurt in your knee, and then it starts to hurt in your hip, and then it starts to hurt in your back, and then it goes away as the inflammation reduces. That's called centralization. So she's experiencing centralization of her L5S1 disc extrusion. And the key to this, the key was knowing that an extruded inferior L5 disc extrusion should not be pulled at L5S1. It should be angled to allow the crevice to reabsorb. Another really cool story. I'm bummed we only have time for 3, but let's get to the third one. If a patient has a spondylolithesis or an anterior lolithesis, that's a very fancy term. If you have it, you know what that term means. If you don't have it, quite frankly, you probably have no idea what I'm talking about. That's okay. When one of the bones slips forward, let's say the L5 slips forward or anterior to the sacrum, and there's kind of a jigsaw puzzle. That's called a spondylolithesis or an anterior lolithesis. It means there's an anterior slippage of the bone relative to the bone below it. I must have seen, I'm thinking of the number 500. I've probably seen 500 spondylolithesis or anterior low or retro, I mean retro like the 80s, like backwards. I've probably seen 500 cases with one of those structural issues. I know exactly how to treat it. You pull flat, you don't angle towards the disc bulge because that'll irritate the structural anterior and posterior. So you have to pull the patient flat, almost like what you think of as a traction when you lay flat, but the sequencing is different. So this patient had a spondylolithesis. We pulled him with 60 degrees or 60 pounds, which is a good amount of pull. And I couldn't pull any longer and even further with that. So if you're walking and you're listening to this, like, what does 60 pounds mean? Like, what does that mean distance-wise? 60 pounds will probably pull the patient about 8 inches of pull on the table. So this patient was getting pulled 8 inches. That's a good amount of weight and a good amount of pull. That's enough. It should be enough to get the disc bulge to reabsorb and to take away a lot of the inflammation around the nerve fixing the problem. It should do that. The problem that we incurred with the patient, the problem that happened is when we pulled him with that much weight, he started to get some bad low back irritation. I could not pull him with 80 pounds. It would have really flared up the patient. So knowing that is super key. Knowing how much weight you can use. Having said that, not going from 60 pounds, naturally the first program of the table goes from 60 to 30. So imagine if 8 inches, it goes 8 inches to 4 inches, back and forth and oscillates, like an accordion, like we talked about. In order to trick the body, I had to trick the brain to not think that the body was under distress to seize and to cause muscle spasms. I had to trick the brain to fix his disc herniation. So what we did is we lowered the weight and I oscillated him from 50 pounds to 40 pounds. So not as far. So I went 6 inches, but I went 6 to 3 or 6 to 5, 6 to 5 back and forth on this oscillation pattern. I totally tricked the brain on the pattern of oscillation. So the muscles, the brain didn't tell the muscles to spasm, and we're able to get a therapeutic benefit. And we fixed his disc herniation and we moved around and navigated his spondylolithesis, and we got him the relief that he wanted and needed. That happens quite often where we have to get that happens often where I have to be very specific about the amount of pull in the accordion-like fashion of the table, whether it's 8 to 4 inches or 7 to 3 or 8 to 7. Very specific, very specific. I'm kind of geeking out about talking about how we use these tables. It's so fascinating. And if you haven't used the tables before, or you don't have enough experience on the tables, you wouldn't even know what the settings are for. Think about that. If you're seeing someone that's doing decompression, I get this all the time on TikTok, on Twitter, on YouTube, on IG. I get this question every 3 to 4 times a week. Hey, I'm doing spinal decompression. It's not working. Okay, that's possible. Let me ask you a few questions. What is going on with you? What's causing your problem? What angle are you getting pulled at? What weight and what frequency? Go. I would say 5 out of 10 times it doesn't align with what I would do. And I could see how that patient may not be getting the results that they should be getting and what they should be doing to fix it. So it's super important that when you're seeking spinal decompression, that you seek a practitioner that knows how to drive the Ferrari. Think about that. You don't want a student driver driving a Ferrari. That would be bad. So I have a network of doctors in California, across the country, that train similar to me, where we've discussed these issues, where they know they are NASCAR drivers. They are Jeff Gordon. They know how to drive the Ferrari, and they can drive it, and they can take you home. That's what you need. So with that said, in closing, these decompression tables, I can't describe how amazing they are. You just heard the nuances from the angle change that we do based on the type of disc injury, on the oscillation pattern based on the injury and the cause of the problem, and then how important it is to know exactly what you're doing on the table. This is why so many people can benefit from spinal decompression. And this is why I'm so passionate about it, because we've seen all these patient results and amazing stories of relief and simply changing people's lives. So if you're looking for help, it doesn't have to be with me. Let me help you find someone that can help you. If you're struggling with something, please message me. Send me a question. Send me what you're doing. What would you like me to talk about next? Or how can I help you? I'd love to help you. I don't have to be the one that helps you. Let me help you find someone to help you, okay? I would not be able to have this platform and discuss these things if it weren't for the sponsors. So again, thank you to Pillowise USA and thank you to PowerPlate. And I really want to thank you for listening to the Back at It with Dr. Decompression podcast. I'd love to help you. Don't forget to subscribe to the podcast. We're on Apple and we're on Spotify. And follow us on Instagram, on YouTube, all the channels. Search Dr. Dudum, you will find me. And so thank you for listening. And next episode, I'll be talking about stress and how Wolff's Law plays a part in what could be happening with your spine. So thanks again for listening.